endoscopic third ventriculostomy and fundamentally focuses on whether endoscopic third ventriculostomy should be combined with choroid plexus coagulation or not. The topic, in fact, reads ETV without CPC does not fulfill its purpose. It gives me great pleasure to introduce to you the two titans who are going to clash, not with swords, but by evidence, this morning, afternoon, or evening, wherever you are on the surface of this planet. Speaking first, Abhaya Kulkarni, Professor of Neurosurgery in the University of Toronto, neurosurgeon at the Hospital for Sick Kids in Toronto, head of the Research Institute, and Program Director of Neurosurgery Residency Program at the University of Toronto. More importantly, a man who has contributed a great deal to our understanding of hydrocephalus, our understanding of endoscopic third ventriculostomy, with or without choroid plexus coagulation. Opposing him from the other side of the Atlantic, and we've made most of our debates transatlantic, a titan who's holidaying in Spain and exhibiting his muscles, a man who came to Liverpool, he says, in 1998 and decided to opt to work in Liverpool primarily because he was a fan of the Liverpool Football Club. I've heard of many reasons for neurosurgeons to opt for hospitals. This is a unique one. I think I've got that right, Conor. Isn't that right?
That's the only and main reason, for sure.
Good. He is now a famous pediatric neurosurgeon at the largest children's hospital in Europe, the Alder Hey Children's Hospital in Liverpool. He's clinical director for the pediatric neurosurgery program in northwestern England, and he's the chairman of the British Pediatric Neurosurgery Research Group. Above all, oh, you lost that last job when you went to Spain, is it? Above all, he's a man, again, who's been very, very interested in shunts and hydrocephalus and endoscopic third ventriculostomy. So we probably have the two pediatric neurosurgeons who have written about, researched, and practiced endoscopic third ventriculostomy and choroid plexus coagulation, or endoscopic third ventriculostomy without choroid plexus coagulation, more than most of us mundane neurosurgeons in the rest of the planet. Enough of an introduction. Start off. Abhaya Kulkarni will tell us that ETV without CPC does not fulfill its purpose. Abhaya, all yours.
Great, thank you very much, Sandip. Thank you for including me in this. Anytime I get to share a stage with my friends Conor and Sandip, even if it's a virtual stage, is a real honor. It's good to see you both, and thank you for including me in this. So as Sandip mentioned, this is set up as a debate, and the premise that he gave us was that ETV without CPC does not fulfill its purpose, and I am supposed to argue that of course it doesn't. So I'm arguing for this statement. Now, I'm always a bit reticent about participating in these debate style formats because it forces us to obviously take one side of an argument and present selective data. And I will do that, of course, in the spirit of this, but I'm going to do this in a bit of a tongue-in-cheek fashion because obviously my actual opinion on this is a bit more nuanced than this simple statement. So we'll work through this, but I will do my best to try to live up to the spirit of the debate. No conflicts of interest relevant to this topic. So the early history, just very briefly, we know this, that targeting the choroid plexus as a treatment for hydrocephalus is well established and dates back over 100 years when using what we would now consider relatively primitive technology and anesthetic issues. People like Lespinasse and Dandy would go after the choroid plexus, either cauterizing it or removing it. These were largely unsuccessful in the sense that the control of hydrocephalus was one aspect, but if you look at some of the series from the 1940s even, the operative mortality was significant, bordering on 40–50%. So really not a great treatment at the time, limited by what the instruments that they had available to them. And then, of course, once shunts came about in the latter half of the last century, CPC as a treatment for hydrocephalus really fell to the wayside. There were a few niche centers that would do it on certain selective cases, but really it was not mainstream therapy. And then we know how it got back into the mainstream, and this was the work that Ben Worf did in Uganda. And this is how we started to think again about what choroid plexus cauterization could offer our patients. And Ben Worf's technique was unique in that he was using a single coronal entry site. He was using a flexible endoscope because that's what he had. He did an endoscopic third ventriculostomy in a standard fashion that we all know. But then he added to that by doing choroid plexus cauterization. And he did this extensive cauterization in both lateral ventricles, performing a septum pellucidotomy if necessary to access the contralateral side. So doing it all through a single entry point. And this was published first in this seminal 2005 work that I still remember the first time I saw this paper and how impressed I was by it, where he did a prospective report on 550 children that he was treating in Uganda. And if you look at the data that he has here, this is one of his summary tables where he's comparing ETV alone to ETV CPC. And look at the results that you're getting. In the under 1 year group, you've got nearly a 20% increase. Not so much of a difference in the over 1 year group, but overall a significant change and improved success rate. So for the purposes of this debate, I'm going to redact that portion of data and just to show you the part favorable to my side of the argument, which is that for at least those under 1 year old, Dr. Worf was showing significant benefit to the addition of CPC to ETV. He broke that table down in a bit more granular fashion. And so here we have, again, comparing the success rate of ETV alone versus ETV CPC, now broken down not just by age, but by the status of the aqueduct, whether it was open or closed, and by etiology of hydrocephalus. And with some of the limitations that they had in imaging and obtaining medical history, of course, the main way that they broke down the etiology for his cohort in Uganda was either it was post-infectious, here the PIH, or non-post-infectious. And we don't have to go into the details of all of this, but really look at the difference that CPC added to virtually every single subcategory here. Nearly 20%, nearly 20%, 4%, but still an increase, over 20%, substantially there, 40%, 20%, again, 25%. This one that didn't show a difference, in fact, showed worsening. So again, I'll ignore that. But for the most part, you see substantial improvement. The other thing I'm going to hide from you are the relatively unflattering p-values. So let's just ignore those. And there's our data, and it's tremendous. So again, I'm being tongue-in-cheek about this because he broke it down so the sample sizes were a bit smaller. But nevertheless, there's clear trend in a quantitatively significant fashion, whether it's statistically significant or not, that there was something positive about what CPC was doing in this population. So that was a relatively small series in a way, but we reanalyzed this data. Sorry, I shouldn't say reanalyze. This is new data, a larger subgroup of patients, 979 patients. And you can see here that if we concentrate here on the choroid plexus cauterization aspect of it, complete choroid plexus cauterization was performed in 34% of the patients, no choroid plexus cauterization in 61% of the patients, and partial in 4% of the patients. So is that of 900 patients or nearly 1,000 patients. So this is nice. As a statistician, when I see this, it's nice to see that there's this variability, because now we can really explore in some detail what the effect of not just choroid plexus cauterization is, but what varying degrees of choroid plexus cauterization does. And so the data that I'm going to show you that resulted in this was different from the first set of data that I showed you from Dr. Worf, because it was a larger series. But more than that, this was data that previous data that I showed you was data that he analyzed. This is data that I analyzed, okay? And I say that to point out that I considered myself independent. This was the first collaboration I had with Dr. Worf, and I came into this as a hopeful skeptic, I would say, is the way to term how I viewed CPC at the time. And so I ran these analyses. He just handed me the data, and we wanted to do a replication of the ETV success score, but for the Uganda patients, because when we tried to apply the standard ETV success score, it did not really work well. And so we thought we needed a separate one for his patients in Uganda. So we did that. And this is the success score, the Cure Children's Hospital of Uganda success score, which accounts for age, etiology. But look at the significant impact that choroid plexus cauterization has on success. All right, to a maximum of 4 points, whereas the other categories give you a maximum of 3 or 2. It's heavily weighted towards choroid plexus cauterization as being a predictor of success. And not just that, but there's a dose response effect here. So that if you do partial choroid plexus cauterization, you're offering the patient some benefit over doing no choroid plexus cauterization. But if you do complete choroid plexus cauterization, you're offering that patient even more benefit. And I remember when I was analyzing this data and the output came through, and I saw this dose response effect. And that was when I first realized, when I was first convinced in myself, this is real. You can't make this stuff up. You can't fake this. This is, when you see a dose response effect like this, to me, that was very powerful evidence that choroid plexus cauterization was in fact offering something beneficial. So going back to the premise that Sandip presented us with, ETV without CPC does not fulfill its purpose. And I think the answer for you in Uganda, from what I've just shown you, is of course it doesn't. Okay, Uganda and probably other similar environments with respect to the types of patient population that they're seeing. I think that evidence is really very clear. Now, I think where it gets a little more tricky is what happens in North America. And I know this is an international audience, and I'm debating somebody from across the Atlantic here. I've said North America not to be exclusionary in any punitive way or nationalistic way, but just because most of the large series outside of Uganda or Africa have come from North America. And I'm not saying that I know there are series from other places, but the bulk of this research outside of Africa has come from North America. So that's what I'm going to talk about because that's where it's from, but it likely has applicability to other similar environments like the one that Conor practices in. So Worf again leads the way on this. And so this is his initial series from Boston, published in 2014, a mixed group of patients that he had here. 57% needed no further surgery, 65% overall shunt-free survival rate. He had various predictors of failure, which is not relevant to this debate. What is relevant here is if you look at the survival curve, this is the success rate of ETV CPC in his cohort of patients in Boston now. And if you look at his patient population and plot the ETV success score, what you'd expect is this. What you'd expect is a 45% success rate at 6 months. What he was reporting was close to a 60% success rate at 6 months. So if you take that at face value, what it's saying is that if you'd only done ETV, you would have had a success rate that's about 15% lower than if you added CPC to that in his population. Okay, there's of course some caveats to that interpretation, but that is one reasonable interpretation of his data and applying the ETV success score to that patient population. And in fact, it becomes more stark when you look at it a bit more carefully, because there is a clear dichotomy with respect to age. Where that is unclear, but 6 months seems to be fairly consistent. And if you look at the success rate for the over 6 months patients, it's really excellent for ETV CPC. He's presented more recent results, so that was 2014 at the pediatric section meeting in December. He presented a larger series of 215 patients who underwent ETV CPC, and he compared them to 73 shunted patients and 19 ETV alone patients. It was a fairly standard mix of the types of etiologies that we see in North America, intraventricular hemorrhage of prematurity, myelomeningocele, aqueductal stenosis being the main group, and most of the patients being under 6 months old. When he looked at the predictors of ETV CPC success, or at least failure, let's say, in his population, age again shows up, a history of prior CSF diversion, and a lower Uganda score. All right, and I will remind you that the big driver of the Uganda score is extent of choroid plexus cauterization. So again, indirectly, what he's showing here is that, as we showed in Africa, in his Boston population, degree of choroid plexus cauterization seems to have some impact and be a driver of success or failure in the Boston population. So if you compare that to the groups here, ETV and ETV CPC, you can see the breakdown in etiologies. You can see the age group here. They're a predominantly younger group, especially the ETV CPC group. The majority were under 6 months, not quite for the ETV alone group. But if you look at the success rates, the numbers are small for ETV, admittedly, but if you look at the success rates, the initial success rate was similar, but when they did repeat ETV and some of the early failures, what they found was that the overall observed shunt freedom rate was substantially higher in ETV CPC group versus the ETV alone group. Now, there's other groups outside of Boston and WARF that have published on ETV CPC in North America. The Miami group is one of them. They've been doing this procedure for quite some time, and since 2007. Their technique differs from WARF in that they use a rigid endoscope rather than WARF's flexible endoscope technique. And that provides an interesting comparison because those of you who've done this procedure know that if you use exclusively a rigid endoscope, you cannot do as extensive a choroid plexus cauterization as you can with a flexible endoscope as you get past the atrium and looking into the temporal horn on both sides. So we do know that just casually looking at the data, the Miami results looked less promising than Boston. And so one can readily ask, is it because they were using a rigid endoscope and therefore had less complete choroid plexus cauterization? And if that's the case, that adds further evidence to the importance of CPC itself. And Shelley Wang, who is one of our former residents here in Toronto and is now on staff, on faculty in Miami, she compared these groups actually. So she took Ben Wharf's series and she took the Miami series and compared them. And you can see here the overall better outcome that the flexible endoscope group had compared to the rigid endoscope. And again, the main difference here was the degree of choroid plexus cauterization was higher in that group. And in fact, when she did her master's in clinical epidemiology, so she did a very nice analysis showing that the unadjusted hazard ratio was in fact significant and significantly showed that the rigid endoscope procedure performs worse. Again, adding further evidence to the fact that CPC, the degree of CPC is important. Now, of course, a good epidemiologist wouldn't stop there. They may perhaps do something like this, where they would adjust the analysis for factors like age, etiology, prior CSF diversion, pre-pontine scarring, all these things. And if, let's say, one were to do that, you might find that the difference between the two groups wasn't significant, which diminishes my earlier argument. But again, we're having a debate, so I'm going to ignore that piece of evidence there, but pretend you didn't see that. All right. Now, the other group that presented on this has been the HCRN. All right. So the Hydrocephalus Clinical Research Network. This is a collaborative group of 14 centers across North America. And I'm part of this network in Toronto. And we work on several collaborative, prospective, largely prospective series and randomized trials to investigate various aspects of hydrocephalus treatment in children. And one of our focus has been choroid plexus cauterization, ETV CPC. We've done a few studies on this, and this was one of the main ones where we did a prospective study across our network on ETV CPC. And the main rationale for doing this prospective study, what we were doing it for, was to see if we could consistently apply eligibility criteria and failure criteria across the network, because our long-term goal at the time that we were doing this was to do a randomized trial. And so one of the things we wanted to see was, can we better quantify the degree of choroid plexus cauterization? We went into this understanding that degree of choroid plexus cauterization is very likely relevant. And up until now, all that we've done is just ask the surgeon at the end of the case, take a guess, how much choroid plexus do you think you cauterized? We wanted to have a more formal way that was more reproducible, that perhaps had greater validity. And so we came up with this diagrammatic method where after the surgery, we had a diagram that broke down the choroid plexus of each ventricle into various sectors, and the surgeon immediately after the surgery had to determine which sectors they were able to cauterize and which they weren't. And from that, we were able to come up with a quantified metric of extent of choroid plexus cauterization to make it a bit more formalized than the surgeon kind of just guessing. So we had 118 patients in this prospective series. You can see the breakdown here. It was a young group. Again, the vast majority under 6 months of age, quite similar to Ben Wharf's population. And etiology-wise, again, the main trio of myelomeningocele, premia IVH, and aqueductal stenosis making up the majority of these patients. If you look at their ETV success score, not surprisingly, they had a low expected chance of success with ETV alone. The vast majority of patients under 50, so under 50% chance of success for this group of patients. And in fact, the majority really under 40 for a 40% chance of ETV success. And we, again, based on the diagrams that we used, we were able to look at how much choroid plexus was cauterized. And you can see here that only in about 3/4 of patients were we able to get the goal of greater than 90% choroid plexus cauterization. That's what we really wanted. And this tells us this, we were still in a learning, individual surgeons were at various points in the learning curve of this procedure. So we've gotten better with this over time. But this was our early experience, and only in about 3/4 of patients were we able to achieve the goal of complete or near complete choroid plexus cauterization. So again, from a statistician's point of view, this is useful data because we have a range of values that allow us to explore what the impact of CPC is. And in fact, when we looked at the predictors of ETV CPC success, once again, like Warfish shown in both Uganda and in Boston, the extent of choroid plexus cauterization was impactful. It made a difference. It was statistically significant, and quantitatively it was strong. The magnitude of this effect is not insignificant. And this is a I'm taking some latitude here with respect to this interpretation, but just to simplify it, essentially what these numbers show is that if you were to do 100% choroid plexus cauterization, that increases your chances of ETV success 4-fold compared to doing no choroid plexus cauterization at all, okay? So that from a magnitude perspective, that's how one would interpret this number. That's not an entirely fair interpretation, but it gives you some sense of the extent to which this was a positive predictor of ETV success. Again, this defeats the purpose of my portion of this debate, but I do have to say this because I can't leave this topic without mentioning one of my main concerns and caveats with ETV CPC is complications. And so I'd be remiss not to mention these. These are the complications that we had. And the one that has really struck out for me that I worry about is seizures. I think this is a high rate of seizures. These are infants, and we don't know why this is. One can postulate. There's some easy ways to postulate why this would be the case. These procedures can take a long time, particularly when you're first learning. There's potentially a use of a lot of irrigant in the brain as you're performing this procedure. Sometimes you get subdural hemorrhages. You've got a scope that's staying in the brain and creating a pathway through this infant brain. So there's a number of reasons, but there's many complications from this, but I do, when I'm speaking to families, I do focus on the seizure aspect because it's higher than I would like. And from other studies, we know that if you have long-term epilepsy and you're a patient with hydrocephalus, that is the most consistent negative determinant of quality of life long-term. So I'm very worried about this seizure aspect. But again, for this debate, let's pretend I never said that. All right, so current HCRN indications. This is how we're broadly functioning right now within our hydrocephalus clinical research network based on the data that we have. We offer ETV CPC to those who have infant hydrocephalus under 2 years of age when they fall into one of these categories, that they're either myelomeningocele who are greater than term corrected age, preemie IVH who are over 6 months corrected age, which of course is a very small niche population, right? That's an unusual category where you're treating hydrocephalus for the first time in a definitive way in somebody who's greater than 6 months corrected age, not just chronological age, but not 6 months post-birth, but 6 months corrected. So that's unusual. So there's not many of these patients around. We exclude post-infectious hydrocephalus, which I have to mention is different than post-infectious hydrocephalus that they see in Uganda. It's an entirely different type of disease, what we see here in North America. And then for all other patients, basically they have to be over 1 month corrected age. Of course, they have to have favorable third ventricular anatomy, and we do detailed MRI, including cis-fiesta images preoperatively to ensure that there's no obvious prepontine adhesions, because that would also be an exclusion criteria. And then we're a collaborative group, so we have all cases reviewed amongst ourselves to ensure that we're all on the same page about whether this child really is a candidate for it, and we try to do this in the context of a research study. And this is the research study that we're trying to do this in the context of now. So we did receive funding for this study last year from the National Institutes of Health. This is going to compare ETV CPC versus shunt in infant hydrocephalus. It's a large 7-year study, multi-center across North America. It's expensive. We should have been recruiting by now, but COVID has delayed that. So hopefully by the fall in some centers, maybe in Canada, we'll start recruiting. I don't know unfortunately, what's happening with the US. But we hope to start recruiting sometime later this year. This is this study is basically modeled after the randomized study we did in Uganda, where we're looking at some of the criteria are different, but we're looking at under 24 months. We're excluding pre-IVH. The primary outcome is going to be a 12-month Bailey cognitive score, and we're going to continue to follow the children to 5 years of age with cognitive, quality of life outcomes, imaging outcomes, including DTI and CSF biomarker outcomes. So I think there's going to be a lot of important data that comes out of that. So hopefully we can talk about that in a few years. And I will end there, and I look forward to Conor's rebuttal. Thank you.
Thank you very much, Abhaya, for a really illuminating talk. It's kind of strange that ETV with CPC seems to do so well in the African continent and also in North America. But somehow the European and Asian community seem to have not got their act together and somehow don't seem to replicate what you managed to do in these two continents. Perhaps we'll hear a little bit about what the UK feels on this, or what is the European position on this, when Conor Mallucci tells us that he does not think that CPC is necessary at all. Conor will take all yours, and we'll talk about the Liverpool football team at the end of your talk.
Thank you, Sandip. Thank you, Ab. It's always a pleasure to have a discussion. I've enjoyed many discussions about ETV over the years. I have to point out my brain is not as big as Ab's in terms of intellect, but I'll do my best. So I'm going to talk a little bit about ETV alone, fulfilling its purpose, but I'm going to go wider than that because I think the debate merits more than a discussion about just ETV. Let me just try and change my slide. We basically fell in love with neuroendoscopy and putting endoscopes in the brain in the 80s and 90s. And we spent 20 or 30 years writing papers that I would argue, and I put my hand up inclusive, were biased, poor evidence base, really trying to convince ourselves that ETV was the new best thing and shunts were evil. And I'm not convinced that we have done ourselves proud in our interpretation of the literature in the last 20 or 30 years with regards to ETV alone, ETV versus shunt, or therefore, or indeed ETV and CPC versus shunt or ETV. What does the literature really tell us? And I'm going to put a few things right. And I think, as I said, we've been rather blinkered, and we've been quoting terrible shunt results to justify doing ETVs in patients who we really shouldn't be. And then we've been adding CPC to ETV to arguably falsely justify doing even more ETVs when we shouldn't be, all in the name of avoiding the evil shunt. So I've worked out, I more or less know most of the time when an ETV is going to work. I've been doing it for 30 years. I kind of know if I do an ETV in a child with IVH under 6 months, it just ain't going to work. Yet I wrote many a paper professing that we should be doing ETV in children under 6 months with IVH purely to avoid the evil shunt. And I said that a success rate of 20 or 30% justified that. I don't think that anymore. I think that's wrong. I don't think we can say that works in 20 or 30% of patients. I think that's ethically wrong. So my problem with CPC, in addition to ETV, is that we've kind of just chucked it in there for all the groups of patients where ETV clearly doesn't work. And there's an argument to say if it does work combined, it's the CPC that's working, not the ETV, because most of the evidence that Ab showed was that actually ETV plus CPC, if anything, works in the under 6 months in children where ETV wouldn't otherwise work. So we add CPC to ETV really just to justify our continued love affair with sticking endoscopes into children's brains. And I'm going to change the literature. And I'm also going to just bring into the fact, if we really think that an ETV is not going to work, why not put a shunt in? You know, we're misrepresenting shunts, and I want to revisit that. Are they that bad? Where is that evidence? So myth one, and shunts. Shunts have such a high infection rate that we can't justify using them, and instead we can justify doing an ETV and a CPC with a worse chance of success, question mark. Well, the HCRN, as Ab has shown, has continuously demonstrated that where we previously quote infection rates of 5 to 20% in pediatric hydrocephalus, actually the risk of shunts is down to about 6%. And if you add in the recent BASICS trial that we published in the Lancet, we've also shown unequivocally that if you use antibiotic impregnated shunts, you can further drop that rate of infection to 2.5% for new shunts. So that old myth that shunts are evil and we can justify playing around with the choroplexus of patients where ETV is not going to work has gone. And we see that the actually the infection rate and the effect in children of antibiotic impregnated shunt, the top right square, infection rates run about 2.5%. In patients over 65, you don't see a line for antibiotic impregnated shunts because the infection rate is 0% with antibiotic impregnated shunts. And in adults, the lower left-hand quarter, we see that the shunt rate is 2.5%. That's for infections with new shunts in all comers. Myth two, BP shunts have an unacceptable mechanical failure rate. We talk about ETV in terms of success, but we always talk about shunts in terms of failure. Why is that? Why can't we talk about them in the same way? The BASICS trial showed, taking all shunts, that actually the success rate of shunts, all etiologies, at 2 years is 75%. The all failure cause of shunts, whatever the cause, was only 25% at 2 years in the BASICS trial. Now in children, if we split the ages, we see that in over 65s, the shunt failure rate at 2 years is about 5%. It's 90% or so. In adults, shunts work better. And in children, it's about 62% of shunts were still functioning for all causes of failure at 2 years. The other old chestnut is that shunts, yes, ETV do fail more often than shunts in the first 6 months, but after that, all ETVs will stay patent and shunts will all fail. Well, that's simply not true. This is our publication on a 10-year follow-up on Mithka valves in pediatric hydrocephalus, and you can see that actually at 3,500 days, which is essentially 10 years, shunts don't continue to drop. These three curves, failure for all causes is the blue one at the bottom. We've still got 60% odd shunts still patent at 5 years. This is the Kulkarni ETV success score calculation, looking at all his patients, showing a very nice failure rate, arguing that ETVs don't fail after 6 months, and that 33%, taking all comers multi-center, beautiful study by Ab, on which he calculated the success score, would show that ETVs would be durable. But I, again, looking at my own data after 10 years of ETV in children, published this result, which shows that it's not as good as it looks. If you publish at 2 years or 3 years, you may well show much better rates, but actually there is a late failure for ETV, and we should be very careful about justifying ETV as a permanent cure for hydrocephalus, and we really need to follow them up for the same length of shunts. And that was pediatric hydrocephalus. When I did it in adults, you can see the top right-hand corner. You can see that even in adults, although the success rate of ETV is better, and it's better in the primary group compared to the secondary group, by 5 years, you've dropped down to 10 years to 55% success rate for secondary ETVs. Primary ETV in adults appear more durable. Sorry, here we go. This is just the same curve. And this is also to show the inconsistency with which we like to interpret the data about ETV. There's all these adult series of ETVs, but they're all talking about apples and pears. Everybody's talking about different etiologies. And really, you can't quote the literature about ETV success unless you can quote your own literature and you can be consistent about the etiologies that you're talking about. Myth number 3, the quality of life is worse for BP shunts. Half the reason that the Ugandan series of ETV and choroplexectomy was proposed was that shunts were terrible and that the quality of life was too risky to risk them. Well, Ab and Jim Drake have published quite a few papers actually indicating that actually quality of life at 5-10 years for ETV or shunt patients is pretty much the same. And they've also gone on to publish further, and we're now going to talk about the infantile international hydrocephalus study. I don't know why people aren't shouting these results from the rooftops, but nobody seems to mention that at 5 years, shunts are doing better than ETVs. So to justify ETV plus choreplexectomy based on the late failure rate of shunts seemed to be a flawed argument, and that modern data would suggest that at 5 years follow-up, shunts are still hanging in there and still doing slightly better than ETVs. And this is for the perfect ETV scenario, children over 6 months with aqueduct stenosis. And yet again, when we look at the 5-year outcome for shunts versus ETV in this lovely pre-plucked group of patients, quality of life, quality of survival, intellect, and all of those indices were the same for ETV or shunt. Myth number 4, better than ETV alone. Well, I'm not so sure. I love and admire Ben Worf's work, but I'm not sure it's translatable to the wider community other than in very, very niche settings. This lovely paper from the New England Journal of Medicine, which Ab published recently, looked at the justification in the first place for ETV plus CPC versus VP shunts, a comparison that we can't avoid. And as far as I can see correctly, VP shunts are doing better than ETV and CPC at 1 year for survival. And there was no difference in cognitive outcome between the two groups at 1 year. And again, the group looked at attitudes regarding endoscopic third ventriculostomy and choreplexectomy and the effect of training in the Cure Children's Hospital. Was this just a Uganda phenomenon? Did you have to be in Uganda? Train there to bring that? And I think, as Ab said, a lot of the North American neurosurgeons did go to Uganda and bring CPC back. But when you actually look at a survey that was done of surgeons that had been, although it's presented in a positive spin, only 41% of trainees that had been to Uganda actually thought ETV and CPC was superior to CSF shunting. A quarter of them thought it was inferior, and 8% felt it was equivalent. And, you know, a third of surgeons who had been there didn't offer ETV and CPC when they went back to their home unit. Although they did demonstrate that they were more likely to offer it as part of the armamentarium when they got back. And this is a hydrocephalus research network study that Ab didn't refer to, but I'm sure we can discuss it at the end. But they did a surgical resource utilization evaluation after initial treatment of infantile hydrocephalus, and they directly compared ETV alone, ETV plus choreoplexus cauterization, and shunt insertion. And if you look at their results, they found that the only group that did worse was the CPC plus ETV group. So if you read through this, ETV plus CPC for initial treatment of hydrocephalus exhibited a higher mean number of hydrocephalus-related revision surgeries than those undergoing ETV alone or CSF shunt insertion. So here we are, the Hydrocephalus Research Network have looked at the implementation of this group in over 1,000 patients, and so far the evidence is not translatable to North America in this particular aspect in terms of revision surgery. When we look at the longer term outcomes at 2, 3, and 5 years, they managed to compare ETV versus shunt. And although they exhibited a trend that ETV, when it was performed, had fewer surgical revisions, it certainly wasn't statistically significant. So again, something to be interpreted with caution. And then we look at this systematic review and meta-analysis of the efficacy and safety of ETV plus choreoplexus cauterization. And they look at how it's been reported in the literature, and you read this box, adverse events mortality reported in 3.7 participants. Publication bias was detected with respect to efficacy and morbidity of the procedure, and a large discrepancy in successes was identified between ETV, CPC in 6 studies from sub-Saharan Africa compared to 3 studies from North America. Conclusion was, quite rightly, that we need long-term prospective multi-center observational studies before addressing its true role. So, my conclusions. ETV, of course, it fulfills its purposes in selected cases of hydrocephalus, but we need to be responsible. We know when ETV is going to work most of the time. We've been doing it for 20 or 30 years. It's a lovely procedure. It's attractive. It's aesthetic. We all prefer doing ETVs than we prefer putting shunts in. But success of ETV alone will relate to your experience and your complication avoidance and your patient selective. Just adding CPC in to justify doing more ETVs where clearly ETV is unlikely to work is a dubious practice. Let's interpret the literature objectively and fairly regarding VP shunts. There's little or no evidence that ETV has better outcome or survival versus VP shunts at present. There really is little or no evidence. There is even less evidence that ETV plus CPC has better outcome than VP shunts or than ETV alone. There is even less quality evidence. So we need to really gather quality evidence prior to adopting ETV plus CPC into routine practice ahead of ETV alone, or indeed ahead of VP shunt. We can't talk about ETV in isolation. We have to talk about ETV, VP shunt, and ETV plus CPC. And at the moment, whether we like it or not, ETV plus CPC is extremely niche. And we really need to gather more information. I look forward to AB's trial before we can endorse it as something that we need to use regularly. Thank you very much.
Thank you very much, Conor. Now things are really hotting up. We have a lot of questions, and I'm going to start off by asking a question of my own. First question, and this is a very contentious issue on a lot of literature about endoscopic third ventriculostomy. What is the outcome? What is a successful ETV? Is a successful ETV a patient who doesn't need to convert to a shunt? Or is a successful ETV an ETV which you can repeat repeatedly and ensure that the patient does clinically well? I'm going to ask this question in the perspective of our own very small work compared to what you guys do. But a lot of infants that we deal with in our part of the world, a lot with post-hemorrhagic hydrocephalus, a substantial amount with post-infective hydrocephalus, we find need a temporary shunt. And after a few months, they don't need a shunt, which is why we've been such strong advocates of ventricular subgaleal shunts in infants. Because we've just sent for publication our study showing that in post-meningomyelocele hydrocephalus, in post-hemorrhagic hydrocephalus, you could probably avoid shunts by doing a temporizing procedure like a ventricular subgaleal shunts in about as high as 60% of these infants. So does that mean that the endoscopic third ventriculostomy with or without choroid plexus coagulation, I'm going to put it to both of you, works because it's working for that period, and after which the infant doesn't actually need an ETV at all and gets over it? So what you're looking at success rate is not the success rate of the procedure per se, but the success rate which is caused by the natural history of the condition. And it's just a thought that I thought I'd address to both of you before we take the questions from the audience.
I think you're absolutely right. I mean, I think that there's clearly a subset of patients with hydrocephalus who probably do have only a temporary need for CSF diversion. You've mentioned this specifically with respect to ETV, but this happens with our shunt patients too. I suspect there's a subgroup of them who the ones who never fail, their shunts may not be working, when they're 15 years old, but we just don't know it. So I think that is a subgroup that exists. I don't know who exactly those patients are, but undoubtedly they exist.
Yeah, Sandip, I agree. And it may well be that it's not actually the ETV that's relevant here, it's the choroid plexectomy. So we haven't really talked about choroid plexectomy alone because you're in there and ETVs are being done, but they might be done unnecessarily. It might just be the having the temporary effect of nothing to do with ETV whatsoever. Who knows?
So are you suggesting that there could be a procedure called endoscopic choroid plexus coagulation without doing an endoscopic third ventriculostomy?
One would argue that these are patients where ETV was never going to work, which is why they've started doing choroid plexus. I mean, the ETV success score on most of these kids who have had success it's probably because of the choroid plexus coagulation, got nothing to do with the ETV. One could argue that. The other thing about Ben Warp's data, a lot of it is it's all CT based. I think that can correct me, but you know, some of the true etiologies of the groups is not entirely clear. And the term idiopathic communicating hydrocephalus or congenital, you know, I've hardly ever seen it in children once you've got high quality MRI scan.
Yeah, I would just to follow up on that point. It's sort of unrelated to your question, Sandip, but just to reiterate, the way I analyze the data from Uganda is that it's specific to Uganda. There's no way I have not taken that data and applied it to any of the patients that I see. I think it's unique to that environment and similar environments, but certainly not to Toronto or Liverpool.
Yeah, the other thing that intrigues me, Abhay, is that, you know, the Uganda series where CPC works so well, if you look at the other paper that Ben Warf published on these Uganda patients, looking at etiology of hydrocephalus, as you know, about 2/3 of the hydrocephalus there were post-infective in origin. Yeah. And then when you look at the Boston series, they say it doesn't work in post-infective hydrocephalus. Now, admitting that the bug in Africa may be different from the bug in Boston, still, do you not think that there's a huge discrepancy in that? Because here you're saying CPC works and the majority of our infants have post-infective hydrocephalus, and there you're saying CPC does not work in post-infective hydrocephalus at all, use it for everything else. And I'm just going to add a little addendum to that question. It makes you wonder sometimes, is one of the reasons why you get a lot of hydrocephalus in post-infective hydrocephalus related to over-secretion by the choroid plexus, because it's inflamed, because of an inflammatory ventriculitis that exists? And is that the reason why in Ben's series, because he coagulated the choroid plexus, they had better results compared to the sort of bugs that you may be seeing in North America? I mean, Correct. This is just something I've been thinking about.
No, I think you're absolutely right. I mean, we've thought about this, and I mentioned in my talk that these are different diseases. Okay, so and it's not. It probably is just the bug as well. But if you look at how we diagnose and how we treat these patients, it's completely different. The prevailing theory is that the post-infectious hydrocephalus you're seeing in Uganda is more of a ventriculitis, as you mentioned, and pathophysiologically it may be more akin to our preemie IVHers than to what we see in North America as a post-infectious hydrocephalus. So there's the pathophysiology of it. The other aspect of it is, though, when you go there, you see that the patients who get treated in Uganda with post-infectious hydrocephalus, most of them did not get adequate treatment, or certainly how we would treat intracranial infection in say North America or Europe or other major centers. And so who survives this and then is able to travel weeks or sometimes months to get to a center for treatment? This is a self-selected group of patients who have a slower, more indolent course of hydrocephalus. They've gotten over an initial infection with or without adequate treatment, and are now suffering a more chronic effect of this. For the cases of post-infectious hydrocephalus that we would see, we're often treating them fairly early after their acute infection is resolved, or sometimes when their infection still isn't resolved, we're having to do some early temporary treatment of hydrocephalus. That's a totally different population. The presentation is different. How their brains have accommodated is different. So yes, we use the term post-infectious hydrocephalus for the Uganda population, but I make very, very clear that has nothing to do with the standard meningitis and stuff that you see in our NICUs and our ICUs in again, Toronto or Liverpool.
But do you think the choroid plexus coagulation actually stops the CSF production in infection more than it does in other pathologies?
That I don't know. I don't have proof of that. As you articulated, it perhaps intuitively may have some validity to it. But I don't have data for that.
Conor, what's your opinion on
that?
I
agree entirely. I'm looking at some of the comments Jeffrey Blount has rightly pointed out. Is one of the differences in Africa is that they've had the infection, they've had to survive before they get to treatment, whereas in North America it may still be active and treated much sooner. So that's a good point. I also know that with gram-negative infections, which we don't see much of. Often CSF production goes right down. We've all seen EVD outputs disappear almost with E. coli and some gram-negative infections. So different infections will have different effects on the choroid plexus, I suspect. And of course, when we put our endoscope into some of these multi-loculated post-infective hydrocephalics, half the choroid plexus is scarred up in some of these cases. So they're all different. So I think we just have to be careful that we don't compare apples to pears, as I said earlier. And I think that, you know, we are talking about niche subgroups of patients, which are relevant to your own demographics.
Yeah, don't worry when you compare apples with pears. I get worried when you compare apples with roses, as we have sometimes been doing. Here's a question from the audience, and this is addressed to Abhay. It says, when you say success, do you mean clinical success or radiological success of ETV? Which to you is more important?
This is a fundamental question, and really gets to the heart of the issue. I think that there's, when you look at any of these series, obviously for the purposes of these talks, we've simplified it and talked about success as individuals, authors have looked at it, which usually amounts to lack of obvious symptoms of raised intracranial pressure, and sometimes that may include some imaging criteria as well. But moving beyond what's already been published, the real question is what really is success, and how are we going to define that? Because that's important to mark out the research agenda heading forward. To me, in an ideal world, what success involves is quality of life. And I say that because there are so many facets to what we think of as success. So yes, surgical success in the sense that you don't need another operation. That's important, you know, we can't deny that, but that can't be to the exclusion of other factors. So how often you're back in the hospital for, even if you don't have surgery, if you just come back to hospital and have to have another MRI or CT scan or shunt series or whatever, that impacts quality of life. So that's one factor to consider. The imaging, I'm less concerned about, because I think what we're trying to get from imaging is it's sort of a biomarker in a sense of really what we're looking for, which is what the clinical impact of your treatment is. Having large or small ventricles in and of itself doesn't matter unless it impacts cognition and quality of life. So, you know, we can just skip over the imaging and go to actually measuring cognition and quality of life. When we look at imaging, it's to try to predict what will happen, right? So that's really what it's for. But in an ideal world, if we knew what the impact is on cognition and quality of life, that's what we would be looking for, and adjusting our treatment according to that. So we've tried to address this in the randomized trial to the best of our abilities. The primary outcome is not surgical failure. We will obviously look at surgical failure, but the primary outcome will be 12-month cognition. That's not ideal either. These are still babies, and there's a lot of limitations in assessing cognition at that young age. But with the practical limits that one has in designing and getting funded a randomized trial, that's what we're using. But we're acknowledging that the real outcome that we're really interested in is going to be at 5 years. And so we're going to look at quality of life and cognition at 5 years, while still looking at all these other things, because we're going to look detailed DTI imaging, CSF biomarkers, because it may be that what we're trying to find out is that you can look at the MRI of a child 3 months after a surgery and say, this is not good. We know that if we don't do anything now, 5 years from now, we're going to find out that their cognition is not up to scratch. In fact, it's a complicated answer. There's not a simple. It's not simple.
That's absolutely correct. I think while you're talking about CSF biomarkers, there's a question from Pat McAllister saying, could you give us some more details about the CSF biomarkers that you're addressing in the ESTHI study?
So that maybe if we can get Pat on, he can probably address that better than I can. And this is actually Dave Limbrick's work, so I don't want to comment on it because it's his sub area of it, and quite honestly, I'm not expert enough to say anything useful that Pat wouldn't have to correct me on and laugh at.
Okay, here's a question for both of you. This is saying that the choroid plexus has been shown to produce a lot of growth factors. Do you think destroying the choroid plexus can actually cause cognitive issues in a child because you just deprive this infant of the various growth factors that the choroid plexus produces?
Yeah, I mean, I think that's the key issue. I think we don't know the answer to that, but it's a real worry. Any destructive process, potentially irreversible. We're arguably heading into a phase where we're promoting this procedure, but not really knowing the outcome. We've got that trial that I published with 1-year outcomes indicating there is no major harm done, but it's in a 1-year outcome in a very poor group of patients. So I am anxious. I'm very anxious about uptake. You know what neurosurgeons are like. We all follow like sheep sometimes, but I do worry that we need to be very cautious about offering any ablative procedure without pretty good evidence. And so I wait AB's trial particularly before, you know, taking this procedure on in a major way.
Okay, here's another question for you, Conor.
Oh, yeah.
You seem to advocate shunts, so something that we haven't heard you do for 30 years or maybe 29 years and 11 months. Which is the group? Would you just look at Abhaya's score and decide who you want to shunt, or when would you decide you want to shunt an infant?
So when I started, I did ETV on everybody and justified 30% success rates as perfectly justifiable to avoid shunts. I've matured since then, as I said earlier. Now, I think if you're offering an operation that has a lower than 50% success rate, you really have to question what you're doing and why you're doing it. And as we look at better evidence from the IIH study that we've just seen, shunts are not as evil as they look. And if you make it a consultant-led procedure, Moritz Chuk style, with meticulous, you know, if we don't bang it down to the trainees, you do it properly yourself. It's a straightforward procedure with a very low complication rate. We're quoting and misquoting historical shunt data inappropriately to sell ETV. Now, I love ETV. Give me a kid with aqueduct stenosis, which is a relatively rare disease, and or a tectal plate glioma, and I'll do an ETV every day of the week. But we even saw in the IIH study that even with the super selected aqueduct stenosis group, shunts do no worse. In fact, they do slightly better than ETV. Nobody is standing on the rooftops and screaming about it. It was almost in an embarrassed undertone that we said shunts do slightly better, because we don't want them to do better. We justify the whole ETV thing as by avoiding shunts. So we have to mature up a bit and just really be slightly more, rounded about what we do. In kids under 6 months, bottom line is I don't do ETV anymore. And that's something that I used to do for year after year in the first 10 or 15 years of my practice.
If I could just add, I think everything Conor said, I completely agree with, actually. The other added element to this about, what the surgeon's threshold for offering ETV is based on success rate. I don't know how you deal with this in your practice, and what you must have these families who come in and you say, it's only 30% chance, so I don't think it's worth doing. And they say, I don't care. I want you to do an ETV. And I've got, very sophisticated parents who come to me with papers in hand, some of my own, and showing me the data. And even when I'm saying, I don't think this is the right thing to do, they want it. And if they'll go someone else if I don't do it. I don't have a good way of handling that. I think I make sure I have an extensive discussion with them, that they do understand what they're getting into. And I think if they do, then I go ahead with it. But that to me is almost more of a challenge than we can have our own thresholds. But these days you've got families and patients who are coming in wanting a procedure. But sometimes it is based on what Conor said, that there's this, it's an unnecessary repudiation of shunts and the horror stories that and certainly some patients do have, that clouds our overall impression of the value of shunts.
Yeah, and just to add to that, I think that's really important. I just think that the literature has changed. There is some much better evidence that we need to be quoting. I don't have a problem with doing an ETV in a child where the success rate is low if the parents want it, but you have to be honest and you have to quote your own results. You know, there's no point in quoting somebody else's results. So you have to put your hand up and say, well, this is why these are my results, and recommend it in a fair way. So yeah, it's still a very personal thing, but I think that we just have to grow up a bit in terms of how we present shunts.
I just remind you of the HCRN paper that Abhaya and company wrote in 2018, where they, and I quote from the paper, where they said clearly that the ETV plus CPC has a higher failure rate than shunt alone in infants. Now, I tell you why I say that, because far away from Liverpool or Spain or Toronto, in parts of the world where I live and various other parts of the world that I go to, which contribute more to the pediatric population on this planet than countries like Canada or the UK do, parents come to us and tell us, look, I've got this child, it may be post-hemorrhagic hydrocephalus, post-infective. They say, hey, look, I want one definitive procedure. I can't come back. I come from a place 2,000 kilometers away. It's not possible for me to come back. So tell me, what can you do? So I don't care whether you put in a shunt or you do an endoscopic third ventriculostomy, you use a rigid scope or a flexible scope, you burn something inside my child's ventricles, as you say, or you don't. I just want to make sure that I can't come back again, number one. And secondly, I may not be able to afford a second treatment in a hurry. So give me one that works best and I have the less chance of coming back to you again. A question I have to face every day of my life. What's your answer to that?
Well, it depends on the age, the etiology, and everything else, Sandip, as you know. Infant, yeah. I mean, the reality is, and I think we all need to accept that the losers in all of this are the under 6-monthers with IVH, post-infective hydro. You know, there is no good treatment for those yet, whether it be ETV or shunt. They all do badly, much worse than kids over 6 months or kids over 2 years. You know, they're two different diseases. And so it's that small group of patients that we don't really have the answer. We're looking for it, but we don't have it. None of the treatments we have on offer for a 3-monther with post-hemorrhagic hydrocephalus are particularly good. Neither ETV nor ETV plus CPC nor IV nor shunt, and they're the commonest group that we see in the Western, you know, in Europe certainly. It changes from etiology to etiology and country to country, but I don't think there's a right answer, Sandip. But actually, where we need to work harder is this group of new patients that do the worst, whatever you do.
Okay, your take on that?
Yeah, I mean, there's no answer to that question that you propose. Obviously, if they want a perfect treatment, maybe come back in 30 years. I don't know. We don't have it now. So the discussion I would have is about an hour-long education session about what hydrocephalus means and what it means for their child heading forward.
Yeah.
Okay, we have an interesting question from a young man called Hal Ricate. And I'm going to read out his question to you. It says, the importance relates to what the CPC is doing. The problem relates to the distensibility of the skull. CPC leads to a slower expansion of the ventricles and distension of the skull. And once the skull is a nearly fixed volume, the pressure can rise sufficiently to stop the development of the ventricles. The subgaleal shunt does the same thing. In the early 70s, Fred Epstein had several studies showing the effectiveness of using an ACE bandage that allowed stabilization of hydrocephalus and preventing the need for a shunt. Do you agree with Hal?
Yes.
It's all yours, Ab.
Well, we've had this discussion, of course, Al and I, and no, I see his point. I think there's probably some. We don't know the true mechanisms by, if you believe this works at all, how it necessarily works, except for how Hal knows. But the rest of us are still trying to figure it out. But I think his theory on this probably has some validity to it. You know, we've discussed this before, and I think there's some rationale to what he's talking about.
Yeah, agreed. Hal, I'll never quite be on Hal's level in my understanding of hydrocephalus, so I'll just have to defer to him on that. But we've had that discussion, and I agree with him.
There's another question from Professor Tomale from Germany saying, do you not think we have too many protocols of shunts or ETVs depending on where in the world we are practicing? And the fundamental problem is that we have a completely different perspective towards the way we're looking at hydrocephalus and its treatment, and we need to universalize it. Yuling has this question.
I mean, Uli, that's a comment, not a question, really, and I agree with him. And you know, the reality is that that we all have slightly different perspectives depending on the demographics of our population. And I also agree with him that there may still be relevant differences in the valves that we use, the protocols that we use, and of course, and the catheters that we use, as we're discovering. So the nuance with shunt development continues to be a challenge. The shunt trial killed the discussion about which valve to use many years ago, but it's not a dead discussion. And I think we all feel that there is a difference between potentially between different valves that we use, gravitational, siphon guards, etc. And we're not in a position to prove it at the moment, but we should continue to do so and not necessarily assume that one shunt's the same as another. And likewise, that we all have the same problem in different countries.
Another question is, what about, is there any role at all of stents in aqueductal stenosis?
I don't practice it. There's been plenty of discussion about it. I don't use it, and that's all I can say. Have any comments?
No, I agree. I don't use it. I think in the setting of aqueductal stenosis, we have good results from ETV alone. This adds another element to it that I have not used personally, and I don't know that the data for it is convincing enough to abandon what most of us do.
Questions are just raining on both of you guys. So you've obviously stirred up a lot of interest, but here's a question that has come, and I think that's a very interesting question, because choroid plexus coagulation, you know, you have this score of determining how much you have coagulated. Do you think a surgeon's assessment of how much choroid plexus he coagulates is a good idea at all? Given that when we did studies looking at extent of resection, we found surgeons' opinions about extent of resection and radiological assessment seem to somewhat differ. So do you think it's a good idea to say how much of the choroid plexus you coagulate is to be determined by the performing surgeon? I mean, if you look at the papers that Sanjeev Bhatia wrote from Miami, they use rigid endoscopes. I'm sure with a rigid endoscope, the extent of choroid plexus coagulation that it could not possibly be the same as you could do with a flexible endoscope. So do you think it's a good idea to use a surgeon's assessment of extent of coagulation as a guide?
Right. No, it's not. Obviously, if we had better ways, we would use it. Right now, that's our best way. We are working on trying to correlate surgeon assessment with MR follow-ups to see what the extent of choroid plexus cauterization is on follow-up MRIs. That will give us a better sense. But yeah, you're absolutely right. It's all we have right now. So it's the best way we can use, but it's not ideal.
Agree.
To both of you, yeah. Do you need to examine the CSF before you do an ETV or choroid plexus in an infant? Do you need to study the CSF before you do the procedure?
It's a good question.
Interestingly enough, this question comes from Bangladesh.
Yeah, I think it's a good question. I think you've written a paper, Sandip, about aqueduct stenosis retrospectively. When you looked at the CSF, had quite a lot of, you were missing infection in quite a large group of patients. I remember your paper. I know certainly when I've done ETVs in infants, when I thought it was aqueduct stenosis, it turns out you see small amounts of hemorrhage, and it was actually a missed periturm intraventricular hemorrhage that caused the aqueduct stenosis. So you could argue you should examine the CSF. How it will change what you do or whether it will avert you from doing an ETV is a different discussion.
Great. I think we've more or less covered everything. One of the questioners point out something that has been mentioned, that we have serious shunt problems in the same percentage of patients that have seizures after choroid plexus coagulation. So how does that make choroid plexus coagulation superior to shunts? At least they cause less seizures in our children.
I'm not sure if I got that right. The reported, you'd expect a lower seizure rate after VP shunts than 5%. Is that what we're saying?
That's correct. This is a question from China, by the way, but yes, that's exactly what the speaker has to say. Saying, you know, seizures are so rare after ventricular peritoneal shunts. They're so much more common after CPCs. It's so difficult to justify to our parents why their children are having seizures after CPC. So why not do a shunt?
Thank you. Yes, you should have put that. I should have put that in my talk, and Ab pointed that out nicely. But I think we're all in agreement. Seizures is a bad sign. You know, it's another negative to be considered heavily when discussing with the parents.
As I mentioned, that's one of, when I have those parents who come in and still want a procedure like this despite a 20-30% expected success rate, I do often focus on the seizure aspect of it for the reasons that I mentioned in my talk.
Great. I think we'll have to spare you guys because there are more questions coming in. But I think we'll have to ultimately call it a day. I'm just going to end with one last question, which says, do you think seizure with CPC is related to the length of the procedure, the washing out of the CSF, and the electrolyte disturbance?
Yeah. I think it's all of those things. The other added factor is you can get some hemorrhage, subdural hemorrhage from decompression as well. So I think all of those things play into this. And these are young brains that we're all operating on. These are all infants.
Great. Well, thank you very much. It's been a very, very informative session. I've learned a lot. And I have to say that ultimately, I think wherever you are, in whichever country or whichever part of the world, ultimately it's what works best in your hands for your patients. We're still looking at evidence, and perhaps both Professor Mallucci and Professor Kulkarni will provide us in the next few years material, information, and results which will tell us very clearly what we need to do. But there is no doubt for the vast majority of neurosurgeons that inhabit this planet, an ETV with a CPC has a very steep learning curve. Putting in a ventricular peritoneal shunt is still a much easier option for vast majority of us who do not have the sort of expertise that our two speakers today have. But thank you very much, Conor and Abhay, you've been fantastic. Thank you very much to all our viewers. And here's the announcement about the next debate, and I'm going to leave you in a little bit of suspense as I say that, because the next debate, of course, is scheduled for the first Friday in August. The topic, intracranial pressure monitoring is necessary in pediatric head injuries. I'll repeat the topic for the next debate. ICP monitoring is necessary in pediatric head injuries. I'm going to leave you with a suspense of who the two speakers are, so watch the space. Thank you. Good morning, good afternoon, or evening, wherever you are. And thanks a lot, Abhay and Conor.
Thank you very much. Thank you, Sandip.